Hi, my name is Olivia Bishop, and I will be doing my sports medicine project on ACL surgery evolution and the bear surgery. To review the anatomy, the anterior cruciate ligament is a band of dense connective tissue that courses from the femur to the tibia or lateral to medial. The ACL is a key structure of the knee joint that helps stabilize the knee. The mechanism of injury is going to be pivoting or cutting motion during a sport, which includes football, basketball, or soccer. The ACL can also tear because of work injuries or car crashes. In some cases, a pop or snap can be felt or heard. To review the years, we'll check over the late 1960s, early 1970s, the 1970s, then the 1980s to 2000s, and lastly the 2000s and a summary of the research about the bear procedure. The late 1960s to the early 1970s. During this period, making a diagnosis of an ACL tear was not noticeable. Clinically, the insufficiency was diagnosed by looking for the anterior drawer at 90 degrees of flexion. The foot was positioned internal, external, and neutral rotations. These tests could not diagnose isolated ruptures and were also positive only when a meniscal damage was present. After diagnosis, a period of cast immobilization and often long periods of rehabilitation. No surgery was performed on the remnant ACL itself. The 1970s. This was when the pivot shift and Lockman's tests were first introduced. The surgeons were allowed to use these tests for diagnosing an ACL tear. There were lots of publications of these dynamic tests in different ways, and were also influential on showing lateral condyle subluxations or reduction of a subluxated position of the lateral tibial plateau. It also aided better understanding of the role the ACL plays. And then in 1967, it's described as an anterior lateral tendinosis using the fascia lata, which limited the gliding. At first, it was combined with a posterior medial embarkation followed by cast immobilization. These results had poor outcomes, with peripheral reconstruction not affording long term stability for the knee. It became evident that attention needed to be directed to reconstructing the ACL. Albert Trillet began his journey based on the technique described, using the patellar tendon and some modifications, with a method subsequently modified by using the medial third of the patellar tendon. Rehabilitation was complex, with postoperative stiffness due to immobilization and incorrect positioning of the graft. During the same period, perhaps because of the difficulties encountered using the patellar tendon, surgeons often offered other techniques using the fascia lata or the extensor mechanism. This technique of using the fascia lata, known most commonly as the Marshall-McIntosh, was most popular in the late 1970s. Some surgeons enhanced the method by tendonizing the proximal end of the quadricep tendon to reinforce the anterior lateral corner. The 1980s to 2000s. First, we have the patellar tendon graft. It consisted of harvesting the middle third of the patellar tendon and using it as a free graft, hence affording a perfect anatomical position. This operation became increasingly popular, the patellar tendon becoming the gold standard of ACL grafts. Fixation of the graft was initially done with wires and extra articular screws. As these techniques improved and gained reliability, they increased the surgical burden on the knee and rendered rehabilitation more difficult without proven functional benefit. The indication of lateral tendinosis persists for some surgeons in cases of significant laxity or a proven anterior ligament injury. The in- introduction of the arthroscope in the late 1970s for meniscal lesions became a playing role in ACL surgery in the late 1980s. The problem proposed by patellar tendon bone blocks into the femoral tunnel drilled from outside in brought some medical companies to introduce new guides that facilitated drilling a femoral tunnel inside out. This option enabled the passage of the transplant. This also introduced new concepts of understanding the insertional anatomy of the ACL as it relates to arthroscopy. The inside out technique remains today, but does not offer ideal anatomical position with actual bone tunnels. Next, we have hamstring grafts. The use of the patellar tendon graft proposed problems during the passage of the bone block proportions of the graft. In addition, risks of patellar fracture and secondary issues of the patellar tendonesis, residual flexion contracture, and anterior knee pain were discovered. The use of the hamstring was thought to be a solution to all these problems. Before becoming a widely used technique, many surgeons have previously used this graft, all utilizing the semitendinosus or gracilis tendon freed proximally to reconstruct the ACL. The first publication describing this technique using the semitendinosus and gracilis was in 1982. The two choices, a patellar tendon or a hamstring graft, are popular today with no fundamental modifications except for different fixation techniques for the hamstrings. Meta-analysis comparing both graft choices showed better control of laxity using the patellar tendon, yet no difference in the functional outcome. Now for after the 2000s. This was when the double bundle was introduced. Even though the results of conventional reconstructions were satisfactory and reliable over time, a positive pivot shift test of varying grades and proportions up to 25% persisted during clinical examination. This lack of rotational control is possibly responsible for secondary meniscal problems, leading surgeons to reconsider the anatomy and biomechanics of the ACL. An awareness of the importance of the anatomical reconstruction of the ACL with two bundles became elementary. Many techniques were proposed in the 1970s, 80s, and 90s, but all had the inconvenience of only having one tunnel in the tibia or femur to mirror the anatomy. The realization of this double bundle theory and procedure raised more clinical issues. This exciting technique was a long and challenging learning curve. It doubles the po- it doubles the possibility of committing an error in positioning. Medium and long-term complications are not well arrested, and a longer follow-up is necessary to judge the superiority of conventional techniques. Now for the bear procedure. Um, the current technique of the bridge enhanced ACL repair, also known as bear, involves placing a resorbable protein based implant containing blood in the gap between the two torn ends of the ACL tear in combination with a suture repair of the ligament. It is hypothesized that patients treated with the bear would have non inferior patient reported outcomes according to the International Knee Documentation Committee subjective score, an instrumented anterior posterior knee laxity, and superior muscle strength 2 years after surgery when compared to patients who underwent ACL reconstruction with an autograft. For the methods, there was 100 patients, all with a median age of 17, with complete ACL injuries, were enrolled and underwent surgery within 45 days of injury. Patients were randomly assigned to receive either Bear or autograft ACLR. There were 65 Bear patients and 35 ACLR patients. Outcomes were assessed at 2 years by an independent examiner blind to the procedure. Patients were unblind after their 2 year visit. The results of this procedure. In total, 96% of the patients returned to their 2 year follow up. Non inferiority criteria were met by the IKDC subjective score and side to side difference of anterior posterior knee laxity. The bear group also had significantly higher hamstring muscle strength index at 2 years than the ACLR group. In addition, 14% of the bear group and 6 of the ACLR group had re injury and required a second ACL surgical procedure, as those percentages can be seen up top. Up here, we have the hamstring strength percentages, and here we have the required secondary surgery. And I would like to go back to this slide just to show that this is a picture of the surgery. So this would be the beginning. These are the sutures that they would put in, and this would be the sponge. Here they have it almost placed in, and they're injecting the patient's blood so that it has a quicker healing time. And then they end up suturing it in, and then immobilization, and then a very laborious um, rehab. Thank you very much for watching my presentation.